Okay, let's start with some practicing. This is an instrument. Okay, there is a clue in this instrument, which is its shape, and also another clue. The tip of the instrument is holding a thread. Can you see the thread? It is little bit, but it is there. So what is the name of this instrument? All of you can recognize this instrument is right angle. Okay, Babcock has a fenestration in its end. Kocher has a tooth, one tooth ended in a groove, another one. Alice is also curved with multiple teeth at the end of it, and the artery is not in this shape completely. These are right angle. And the thread which is held because the surgeon is preparing to pass a thread around a longitudinal structure. So the same pictures will come to your colleague on next chair with another questions. What this instrument used for? Passing a thread around longitudinal structures. Again, look to the photo first. Photo is an instrument. Okay, what kind of instrument? It's not an original instrument. It's not with a handle and a blade. No, it's just like the forceps which you are used to pick up your hair or something. So this is a forceps. Look to its end. Is it toothed forceps or not toothed forceps? This is non-toothed forceps. The question is what this instrument is used for. Because it's non-toothed, so it is to hold something. Is it for hemostasis? No. The hemostasis usually use artery. Towel draping? No. The towel draping is with lock and it has to hold the towel. Holding the aorta? No. To manipulate any vessels, you have to use a specific forceps, vascular forceps, which is not in your focus. Because some of you will say to me, please show me the vascular forceps. No, it's not in your focus. So it's one of two things, holding soft structure like intestine or holding tough structure like skin. Which one you think about? This is non-tooth. So holding soft structure like intestine. Please turn off your mics. Thank you. Okay, look through the pictures. Don't look to the questions at all, as it wasn't there. This is an operative view of a patient. The umbilicus is there. It's present at the edge of the draping. So this is a lower part of right side, lower part of the abdomen. Small oblique incision and a structures blinded ended like a worm attached to the intestine is there. A lot of questions. Let's start with the questions which is there. What is the operation? Is operation shown? Is it operation for right hemicolectomy? Would we do right hemicolectomy in a small incision in right lower abdomen? No. Polypectomy, removing a polyp from a lumen of the intestine. We don't use this by surgery. We use it by endoscopy. Duodenectomy, there is nothing called duodenectomy. We couldn't excise the duodenum. Most of the cases, the duodenum is a free part of malignancy, except in Whipple. Pyloric myomectomy, this is done in a babies in hypertrophic pyloric stenosis, and it's usually the incision is up above the umbilicus, and it's olive-like tumors which we incise it until bulging of mucosa. So it is appendectomy or appendectomy. A lot of questions can be done on this operation. What's its complications? What's its presentations? What is the incisions used to do appendectomy through? The common incision is McBurney incision, but little incision is better because it's more transverse, and also we can now do laparoscopic appendectomy through a laparoscopic in multiple small incisions. Look to the photo. It's not clear. Sometimes when it's not clear, you can look to the heading of the questions. But this photo has a clue. This is umbilical cord. Umbilical cord. If you can remember it from the gynecology. Umbilical cord. This is anterior abdominal wall of a baby. Umbilical cord usually is attached to the baby where? In his head, in his leg, in his umbilicus. So instead of the umbilicus, normal umbilicus, there is a bulged yellowish sac. So with aiding also of reading the heading of the question, in this picture of a newborn, he is a newborn. What is the congenital anomaly shows? Congenital anomaly shows absence of the umbilicus with bulging of the intestine through a small, very translucent, yellowish, membranous sac. Is it inguinal hernia? No. Is it meningocele? No, meningocele in the dorsum of the head or the lower part of the back of the vertebrae. Is it ectopic vesica? Ectopia vesica in the lower abdomen, not in the umbilicus. Hiatal hernia? No, this inside with stomach and esophagus. So it's omphaloceal, which is a congenital hernia through a defect in the umbilical stump. You will see that most of the photo-oriented questions is an easy question, very easy questions. We consider it as easy. When we planning for an exam for you, we prepare the exam by putting 1/3 of the questions easy, 1/3 of the questions medium, 1/3 of the questions average, and only 10% 30 and 10% hard. 10% hard for just knowing the most perfect one of you. But if you are average, you can solve 75% of these models of exam. Most of the questions oriented photo oriented questions is easy. Look to the photo. It's a specimen coming out from a patient, but we don't know which part of the body is excising this. We can go to the heading of the question. What is the pathology of this specimen excised from the breast? From the breast. So this incision from the breast, and this swelling excised from the breast. What is the characters of this swelling? By looking to the pictures. It is capsulated. Does it? Yes. Well circumscribed. Surface is lobulated. Vasculature is fair. Some parts is bloody, some part is fibrotic. So, does this give you an idea that this is a cancer or malignant, or it's benign? I think it's benign. Coming out from the breast, what is the commonest benign lesions of the breast coming out of it by excision like this? Let's go to the options. Cancer breast? No. Carcinoma in situ? No. Fibroadenoma? Probably yes. Fibrocystic disease? We don't excise a fibrocystic disease. Fibrocystic disease is not treated by surgery usually. Ductictasia? Ductictasia means dilatation of retroareolar major ducts. You are kidding. So this is a fibroadenoma. A lot of questions about fibroadenoma. What is the best method for treatment of fibroadenoma? Excision biopsy. Do you need a safety margin to be excised with fibroadenoma? The answer is no. Even 1 millimeter, even no 1 millimeter. No, you don't have a safety margin. A clinically presented patient, a left leg of a patient. Can you describe what you can see? Each one of you take a 30 seconds to describe what you can see in this photo. Don't take care about the question at all. Don't read the questions. Concentrate on photo. Suppose that this is a patient lying down in bed and you are on OSCE exam. Each one of you is going to OSCE exam. Your number, your name. Please inspect the leg of this gentleman. Describe. In 30 seconds, each one of you have a pencil and write down what he will say. Okay, each one of you will mark himself. If you say, first of all, if you move with your body and look around, all around the leg, and move the patient, excuse him, and move the leg to the right side and left side of the leg, and look to the other side of the leg. By doing this maneuver, you already took the half of the mark. By inspection only, this is enough. If you had been asked about palpation and you tested the force of the muscles of this patient, and you palpate for dorsalis pedis and postiotibial and antiotibial and popliteal of this patient, pressing to check if there is edema or not. By doing this, you have took the half of the mark without saying any words. But if you want to say, I can see a patient who has a big, huge ulcer extended from the posterior part of the lower half of the leg and extended to the lower part of the medial aspect of the left leg, just above the medial malleus. The ulcer is oval in shape, about 20 by 10 centimeter, has a sloping edge in most of the edges, has a reddish, healthy floor. Also, this ulcer is surrounded by blackish, dark, browny, edematous pigmentation of all around the lower third of the leg. If you ask the patient to stand up and see if there is varicose vein or not, this is good, well and good. Okay? If you ask to be palpate, you have to comment on edema, pulsation, movement of the base of this ulcer. Every one of you had marked himself. Let's go to the question. What's the most common cause of this ulcer? Each one of you can answer now. The arterial ulcer is not present there. The arterial ulcer is on the tip of the fingers, of the toes, sorry. Venous ulcer, yes, this is venous ulcer. Neurogenic, usually on a pressure point. Diabetic, usually on the pressure point, because it's most of causes is neurogenic with ischemia and hyper level of glucose level in blood. Malignant ulcer, is there everted edges of this ulcer? No. So these are venous ulcer. As I told you, it's a very easy type of questions. Okay, look at the picture. Don't look at the question. It's a face of a patient. It's apparently that the right eye area is edematous, reddish, swollen, puffy. Also, there is a small defect in the skin in the lower medial part of the right eye, squeezing from it a yellowish thick pus. What's this? This acute cellulitis, acute inflammation of the subcutaneous area surrounding the right eye, with subpuration of a part of it. This photo shows acute abscess, erysipelas, chronic abscess, cellulitis, ecchymosis. You are confusing between acute abscess and cellulitis, but there is a pus, so it's acute abscess. The same picture, the same photo with another questions. What is the most dangerous complications of these patients? Cavernous sinus thrombosis. Had you heard about this? Cavernous sinus thrombosis, because this inflammation and abscess in a dangerous area of the face. What is the dangerous area of the face? It's the triangle between both lateral angle of your eyes and the lateral angle of your mouth. Look to the pictures. What you can see, it's a specimen coming out from patient, which show a sac, blinded-ended, with a fundibulum and the duct. The wall of the sac is thickened. Can you see the thick wall of the sac, especially in this area? This means chronic inflammation. The sac is filled with multiple, variable size and shape, hard stones, darkly variable pigmentation, with fascinated surface for each others. Most probably, this is gallbladder filled with, is it pigmented stone? Is that cholesterol stone? Or this mixed stone? So I can ask about what is the organ shown in the photo? Gallbladder. What is the disease? Chronic cholecystitis. What is the type of stones? Mixed stones. How usually you treat this patient? By laparoscopic cholecystectomy. Most of these patients is presented by asymptomatic. If the pain in this patient, where is the most common area of pain in this area of this patient? Right hypochondria. Where is the area the pain radiated to? The lower part, the lower angle of the right scapula and shoulder. So multiple questions about one photo. What's the type of stone shown in the photo? You can answer. It's mixed. This is an X-ray. Is it X-ray, plain X-ray without dye on it, or with dye on it? It is an X-ray with dye on it. To recognize where we are in the human body by this X-ray, we have to concentrate on two things. First thing, the bony mark, the bony mark. And second thing, the shape of the organ which the dye is presented in. Let's concentrate on the first part. What is the bony things which you can see in these pictures? I can see here a rib, another rib, a third rib, three ribs down. And this is the ribs coming from the vertebral column. So these ribs coming parallel from the vertebral column. So I am in the chest, near the vertebral column, either in the upper chest or lower chest. If I am in the upper chest, usually the lung there and it's clearly black. I am not in the upper in the chest. I am in the lower in the chest. And also I can see here the hue of the diaphragm. I am on the left lower part of the chest. Lower chest and upper abdomen. In fact, this is not an abdomen. This is a thoracic abdomen, which is the abdomen which is hidden behind the costal margin. So I recognize where I am. What is the organ? The organ is filled with barium, white things. It is tubular structure in the chest coming down, passing through the diaphragm and filling an organ with rouget. So, this is stomach, this is esophagus, this is abnormality. So this gastroesophageal junction filled with barium, so barium meal. What's the abnormality? A part of the stomach is herniated through the esophageal orifice to the thorax, causing hiatal hernia. The question, what's the type of the X-ray? Barium enema, plain X-ray abdomen, barium follow through, which shows the intestine, barium swallow, which show all the esophagus. No, it's barium meal. If you want to be very specifically, this is a barium meal in Trendelenburg position. What's mean? Mean I fill the stomach with barium and I put the patient in head down position. So the upper part of the fundus of the stomach will be filled by barium. And this is the ideal position to show hiatal hernia. Again, because it sometimes comes in a question. barrier meal with Trendberg position. Trendberg position means head down position. Okay, another questions. What is the kind of hiatal hernia you can see in this photo? So there is a types of hiatal hernia: sliding hiatal hernia, paraesophageal or enrolled hiatal hernia, combined. Which type is that? Is it sliding? Is it enrolled? Or is it combined? This is combined because part of the hernia is sliding in this fundibular and this part is paraesophageal. It's combined. The same picture with different question. What's the diagnosed pathology of this X-ray study? Cancer stomach, peptic ulcer, cancer esophagus, hiatal hernia, cancer cecum. The answer is hiatal hernia. Concentrate on a photo. It's an X-ray. Is it plain X-ray or X-ray with a dye? The only things which confuse you, this part, which you think that it's a dye. But this is an old gentleman. Let's concentrate on bony structure and we will see what this. On bony structure, you can see the vertebrae, which is square-like shaped. The upper vertebrae ribs coming out from it, but the lower one not. So this is the lumbar vertebrae, this is the lower thoracic, and this is the lower ribs. Also, I can see the hip bone, the left hip bone, the right hip bone, the pelvic brim. So what's that? This is Ostenmeyer hip replacement prosthesis in an old patient. But still, this is an X-ray of the abdomen. And it is plain X-ray or X-ray with dye? Plain X-ray. So I recognize the anatomy, the bony prominent, and the cell area. What's abnormal on it? The abnormal on it, what we called bean-shaped dilatation of the large intestine. Bean-shaped, like a qahwa, bean. Or sometimes we call it tire-shaped dilatation of the sigmoid colon. This is huge dilatation of a part of the colon. This huge dilatation cannot be small intestine. It's a large intestine. And usually it is a part of a large intestine which is mobile, which is sigmoid area. This is a classical picture of volvulus of the sigmoid, which is very common in old age patients. Let's go to the questions. What is the radiological diagnosis? Volvulus cecum, volvulus stomach, volvulus ileum, volvulus jejunum, volvulus sigmoid. In fact, there is nothing called volvulus ileum except in young congenital and jejunum. Volvulus stomach is very rare and it's usually in the upper tummy. Volvulus cecum, it's small. The cecum is very small, but volvulus sigmoid, which cause this distended dilatation. The same pictures can be with another questions. What is the most common presentation of this patient? Abdominal distension with absolute constipation in old age patient. What is the best methods of treatment for this gentleman? Endoscopy. Just endoscopy can revolve the volvulus and relieve the condition in early cases. What is the treatment in late cases? Resuscitation of the patient, laparotomy, and sigmoidectomy. Could we do sigmoidectomy with resection and anastomosis in this condition? No. This colon is not prepared. This is an urgent condition. So if I have to remove the sigmoid, I have to do a Hartmann procedure, which is a closure of the rectal stump and putting the proximal colon as an end colostomy, temporary. Look to the picture. Don't look to the questions. The pictures is a transverse section of a part of your body. Which part? Look to the bony area. There is vertebrae, paravertebral muscle, and this white one is ribs. ribs. So we are in the chest, but there is no lung, there is no heart. We are in thoracic abdomen. We are in the upper abdomen. So this is CT, transverse section of upper abdomen. I hear one of you said it's a CT, doctor. No, this if asking you about what this and I have this in your hand during the exam or something, the best thing is an CT upper abdomen transverse section. The second question is it with intravenous dye or without intravenous dye? Look to the aorta, which is a circular disc in front of the vertebra. Can you see it? Is it looks white? So this is a CT upper abdomen transverse section with intravenous dye. Sometimes I bring these pictures and make an arrow. For example, on this. What's this? The question is what the arrow is pointed to? The answer is spleen. What is that? The answer is stomach. What is that? Left lobe of the liver. What's that? Right lobe of the liver. What is that? Right kidney. What's that? Left kidney. What's these transverse structures which is crossing in the upper abdomen? It's pancreas. So the same pictures will be presented to 5 students with 5 different questions. But the point is, if the student can recognize what is the picture is, it's very easy to answer questions. What is the type of imaging technique? It's CT upper abdomen with contrast. Look to the picture. What is there? It's an X-ray of a limb. It is the knee and the upper leg, bilateral. Is there a dye on this photo? Yes, there is a dye. What is the structure taking the dye inside? It's a vessel. So this arteriogram of the popliteal artery and anterior and posterior tibial artery. Is it clear? On the right side, there is clear, good attenuation of the popliteal and the anterior tibial. Posterior tibial is slightly irregular and corrugated. On the left side, there is missed part on posterior tibial. Anterior tibial is completely closed or occluded. A lot of questions about this X-ray. What is the type of imaging technique? This CT angio, this CT bone, MRI bone, venogram. Venogram is not done nowadays. Plain X-ray? No, this is a CT angio. Another questions. What is abnormal in this condition? Irregular filling defects in the left posterior tibial and absolute occlusion of the left anterior tibial. What is this patient presented with? Symptoms of ischemia, both lower limb with more on the left side. Is this patient candidate for percutaneous angioplasty? The answer is no. This is a multiple level stenosis, very long segment. What's the type of this? Oh, sorry, I did the mistake. What I did, I read the questions. Go to the photo. The photo is X-ray. Photo is an X-ray with dye in a structures. But in this X-ray, there is something foreign body or foreign instrument, which is very characteristic. This is a picture of endoscope. This is the glass fibers which carry the light from the light source to the down the endoscope. And this is the side view endoscope. So because the endoscope is in the stomach, passing through the duodenum to the second part of the duodenum, and trying to cannulate what's in the second part of the duodenum, sphincter of Oddi, and this is the common bile ducts, but it's abnormally hugely dilated, and a lot of multiple filling defects presented in its lower half. Also, there is a dilatation of intrahepatic biliary radicals. This technique is called endoscopic retrograde pancreaticocholangiography. Endoscopic retrograde cholangiopancreatography, ERCP. MRCP is another way to visualize the biliary without this endoscope. BTC is another percutaneous transhepatic cholangiogram. It's another way to see the biliary through a needle stick from outside to a dilated biliary radicals. CT is another way, and ultrasound is another way. All this is a techniques to visualize the biliary, but what is present in this photo is ERCP. What's this structure? The answer is nasogastric tube, Sangustichian tube. It's a stent, it's a probe, it's the endoscope. This is the endoscope. An X-ray. Plain with dye? No, it's with dye. Some dyes there in structures. First, I want to recognize which area I am in the body. I can see a square-like vertebrae. It's very clear. The upper one has a rib. So this is the last thoracic vertebrae, first, second, third lumbar vertebrae. And this is the right side of the upper abdomen. Right side of the upper abdomen. Good. Until now, we are good. There is a dye filling a tree-like structure in the right side of the upper abdomen, which is the biliary tree, and this is the common bile duct. Also, the dye is escaped to the duodenum with its rugae. The dye is present there through injection of this drain. What kind of this drain? Look concentrated to this limb, which is divided to two limbs here. This is a T-tube. T-tube, which we are inserting it inside within the common bile duct after exploration of the common bile duct to drain the bile to the outside, because after manipulation of biliary tree with opening, section, and extraction of the stone, there is an ileus of the tree. If I leave it without draining, the bile which is excreted from the liver will fill all the abdomen and cause peritonitis. So I put a T-tube. The first indication for T-tube to drain the bile outside until the biliary tree movement coming back. Secondly, before I remove the T-tube, I can inject a dye from outside through the T-tube, calling T-tube cholangiogram. In this case, there is a dilatation of common bile duct, and there is a missed stone. Missed stone in the lower part of the common bile duct. Go to the question. What is the type of this imaging technique for biliary tree? This is a T-tube cholangiogram. T-tube cholangiogram or cholecystogram. Same picture, but with another questions. What is the abnormal finding in this cholecystogram? A missed stone in the upper part of common bile duct, or a missed stone in the lower part of common bile duct? A missed stone in the lower part of common bile duct. It's another way of a picture of a things which you have already saw before. Concentrate on a bony structures. What's this part of your body? Is it plain X-ray or X-ray with a dye? What's the abnormality on it? What's this dilated tire-shaped large intestine? And the question is, what is the type of X-ray? It's a plain X-ray of abdomen. The answer is a plain X-ray of abdomen. What is the positive finding in this X-ray? Dilatation of the colon, dilatation of small intestine, dilatation of the stomach, multiple air fluid levels, air under the diaphragm. Which one you choose? Dilatation of the colon. One of you said, doctor, I am searching for the tire-shaped dilatation, and I can see it. I can put a question in all the ways that I test if you had understand this X-ray or not, to practice it in your life and to treat patients. Look to the photo. It's an X-ray. Look to the bony areas. There's a multiple ribs and vertebrae, and the shadow of the diaphragm. This is the left one and this is the right one. It's not anteroposterior, it's oblique one. Usually we do oblique one to see the esophageal hiatus better, because in the anteroposterior sharp, the hiatus of the esophagus is overlapped with the vertebrae. Is there a dye there or not? Yes, there is a dye filling the lower part of the esophagus and the part of the stomach. What's the abnormal? This is not a usual esophagus. This is a very huge dilated esophagus. The esophagus is usually like a tube. Is there a hiatal hernia? Is the part of Roget of the stomach is above the flag? No, no, no. But there is a stenosis in the gastroesophageal junction. This stenosis is smooth or irregular? Very smooth. Huh? The question, what's the type of X-ray? Is this barium meal or barium swallow? This is a barium swallow, because the problem is in the esophagus. Yes, some of the barium go to the stomach, but if I want to photo the stomach, I will photo the upper part of the abdomen, not the chest. What is the abnormal is this? This is achalasia of the esophagus. I don't know if you heard about achalasia of the esophagus or not. What's the pathology shown in this barium study? Cancer esophagus is usually irregular. Esophageal varices, multiple finger defect, which is not there. Cancer stomach, the stomach is not the organ is to be tested. Hiatal hernia, no, there is nothing with Roget above the diaphragm. So it is achalasia of the esophagus. Oh, another barium swallow. This is the diaphragm, this is the esophagus. The caliber of the esophagus is not too much dilated, but there is a multiple, irregular, variable in size and shape, filling defects, most of the lower and the middle part of the esophagus. This is a classical photo of barium swallow of esophageal varices. Barium swallow of esophageal varices. This is X-ray. Which part of your body? I don't know. This is a vertebrae. Yes. The vertebrae is square in shape. Yes. And there is a last strip there. So this is an abdomen. And also I can see the pelvic bone, hip bone, right hand side. So it's an X-ray of the abdomen, anteroposterior plane. But during plane X-ray, I can see a multiple, variable size, fascinated surface, shaped, radio-opaque, shadows, most probably stones, filling the gallbladder. Or this is filling the dilated huge ureter. Or this is multiple stones in the pelvis of the kidney. Is it applicable, all this? Yes. So, if I'm in doubt, is it in the gallbladder? Is it in the ureter? Is it in the kidney? I will do lateral plane X-ray, lateral view. Plane X-ray, lateral view. The gall and the kidney and ureter would be presented in the posterior part of it. So it's a very important question to differentiate the right side, right hypochondrial radio-opaque shadows. The questions of this photo is what's the type of X-ray? It's a plain X-ray abdomen. Plain X-ray abdomen. What's the next step to do with showing finding? What is the next step to do with showing finding? Should I do ultrasound abdomen or CT abdomen or lateral brain X-ray abdomen or barium meal or MRI abdomen? I should do lateral plane X-ray abdomen to see if it is in the gallbladder or it is in the... After that, I will do what is it supposed to do. Look to the photo. The photo is an instrument. It's not an ordinary instrument with a handle and the blade. This looks something which we hold by our hand, and this is the acting part. The acting part is wide and curved, so retract something. The size of the retracting part is big, so it is abdominal retractor. It's not a skin retractor, right? Second thing, is it a self-retaining retractor or non-self-retaining? It's non-self-retaining. The assistant should hold it all the time. Why we put this curving in the handle? To have a good grip. This foramina is putting the index finger inside it and have a good grip. This is good. But what about the olive fenestration? I cannot put my hand on it. This is to make the instrument lighter in weight because you hold it all the time, non-self-retaining. We have to make it lighter for you. The question, what this? It's a non-self-retaining abdominal tractors. The reason of the presence of a round and a long hole in the handle of this instrument is to make it wider for more retraction? No. This is the area to retract. Better hemostasis? No. Better visual through the holes? Are you imagining this? Makes the instrument light in weight? Yes. Makes the instrument easier to cleaning? No. If they remove the number Z and put make the instrument easier to be holded, yes. The cause of presence of a serration in the handle of this instrument, the same, but it's different shape of a non-self-retaining abdominal tractor, is to make it serration D, to make it a good gripping. Make it wider for more retraction? No. Make the instrument easier to clean? No. Decrease the cost of the instrument? No. Better gripping by the assistant? Yes. Make the instrument lighter in weight? No, because there is no fenestration.